do a class on aortopulmonary window, etc., with quiz questions mainly. So we'll get started. This is an angiogram, AP view, pigtail catheter. So what is the diagnosis on this one? Diagnosis, anyone? Everyone can see the angio? Hello? Anyone? AP view, pigtail catheter, root aortogram. You can see it's a right arch, right descent. What is the diagnosis? So everyone thought AP window, so I said AP window, etc. So it's not just AP window. So you see here, when you inject, watch in the root. Let's see, I'll just try and freeze it. Here, pigtail injecting. And what do you see there? You see the left pulmonary artery coming off from the root of the aorta. You don't see a right pulmonary artery. So the difference between this and an AP window, in an AP window generally you would see then both the branches getting filled. Here you're seeing the left pulmonary artery. So yes, the diagnosis is LPA from ascending aorta, or what is colloquially called hemi-truncus. So this is a hemi-truncus with the LPA from the ascending aorta, also called anomalous origin of one single pulmonary artery from the ascending aorta. Now, which one is more common? Right PA from aorta or LPA from aorta? Which is more common? So, right PA from aorta is more common. So, what you are seeing here, LPA from aorta, is quite uncommon, seen only in 16% of cases. 84% of the time, hemi-truncus is RPA from ascending aorta. Now, where does the RPA typically arise from? From which part of the ascending aorta does it arise? Anyone? Where does it typically arise from? So it can arise from the ascending aorta close to the aortic valve, right? So let's go back to that angio. If you look at this angio here, you see here, it's arising relatively close to the aortic valve. So this is the most common form. It occurs in 85% of patients. In some of them, it will arise close to the brachiocephalic artery and rarely from the base of the artery itself. That's the distal form. So most common is right pulmonary artery from ascending aorta, that type of hemi-truncus, and occurs in about 85% of patients. It is a proximal variety, very close to the aortic valve. Okay? All clear? Next question. What are the common associated anomalies with hemi-truncus? So what are the common associated anomalies with hemi-truncus? Anyone? With RPA from aorta, with LPA from aorta. Anyone? No one read hemi-truncus? ASD, okay, but what are like more typical things when you think of hemi-truncus, common associations? So all of you read today, but tetralogy of Fallot, yes, TOF is commonly associated. And is that tetralogy of Fallot associated with RPA from aorta or LPA from aorta? And the other things associated are right aortic arch. So you saw the case I just showed you, right aortic arch, that's an association with hemi-truncus. Now, tetralogy of Fallot with which one? RPA or LPA from aorta? So, LPA from aorta. So the case that I just showed you, which is a right aortic arch with an LPA from aorta, is associated with tetralogy of Fallot in 74% of cases. So high association of left hemi-truncus with tetralogy of fellow. Other associations, if it's an RPA from aorta, you can have interrupted aortic arch, you can get AP windows, you can have VSD, you can have PDA, which is actually the most common associated anomaly. Now the pitfall is that, when you have an LPA from the aorta and you have a PDA, think about it. Sometimes it can look to you like it's normal branch pulmonary arteries. So these associations are important because you can have LPA and RPA from the aorta, but each of them is different. See, if you see LPA from aorta is associated with right arch tetralogy, RPA from aorta with things like interrupted arch AP window. So they actually have different embryologies and different associations. Okay, all clear on this? So I hope this case, I want to go back to it so that you all look at it again. So watch this case. Left hemi-truncus with right aortic arch, common association would be tetralogy of fellow. Okay, next question. When you have a hemi-truncus, when you have one PA coming off the aorta, what is the pulmonary artery pressure in the normally connected lung? So say your RPA is coming off from the RV. What is the pressure there? Is it normal or is it high? So if left, in this case, left pulmonary artery is coming off aorta. So obviously it has high pressure. It has systemic hypertension. But what about the normal lung, the normal artery? Does it have a high pressure or normal? And yes, it has a high pressure. Why does it have a high pressure? Even though the normal lung is not coming off the aorta, why does it still have a high pressure? And the answer is because it gets the venous return of the whole body. Remember that. If you have your RV giving rise to MPA, giving rise to RPA, what is the RV getting? SVC blood and IVC blood, right? So all the systemic venous return of the body is going to that single lung. So even though that single lung is not connected to the aorta, it also lands up having a high pressure. So you get pulmonary hypertension in the lung, in the hemi-truncus lung, and you get pulmonary hypertension in the normally connected lung as well. Okay, all clear on that? So now we'll move to the next question. What is the treatment of hemi-truncus? How do you treat it? When do you do it? And what do you look for on follow-up? So treatment is what? Anyone? What is the treatment of a hemi-truncus? Why no one's answering? How do you treat it? So it's connected, ALP is connected to aorta. So treatment? Anyone? What is the surgical treatment of hemi-truncus? So you disconnect the PA from the aorta and you reconnect it to the pulmonary artery, right? When should this be done? What age should this be done at? When would you treat a hemi-truncus? Say I diagnose it at birth. When do you want to treat it? Anyone? Surgical anastomosis of PA back to MPA, and the treatment is as soon as possible. Because remember, in a hemi-truncus, nothing is going to get better, right? It's not like now the artery is going to improve and somehow get magically closed. So you have to reconnect it. So once you diagnose it, you plan for surgery. There's not much benefit in waiting. And on follow-up, what do you look for after treatment of a hemi-truncus? You've taken off the PA from the aorta, now you've connected it back to the MPA. So you have to look for stenosis, pulmonary artery stenosis, supravalvular stenosis. Because where you repair the aortic area, you may have scarring or pulmonary artery stenosis. Clear on this? Kavita, everyone can hear, right? Because no one's answering. Guys, we'll move on to this. Name the only condition in which a major vascular structure passes between the trachea and esophagus. Anyone? Vascular structure passes between trachea and esophagus. So it's a vascular ring. Which one? What's the name? Which is this? When the vascular structure goes between trachea and esophagus, it is an LPA sling. So if you see here, this is a CT image on the left. So the LPA sling, the LPA goes behind the trachea and in front of the esophagus. So that is your LPA sling. What is your diagnosis here? This is a long axis view. I've labeled everything for you. Aorta, LV. What is the T? What is that? Anyone? Long axis view, you see something like that. Well, you won't on a long axis view really see your trachea, right? The trachea you're going to see only when you do a suprasternal. And generally it will look like rings. So this is not the trachea. It's just labeled as T. What connects between, okay, that's a good thought, pseudoaneurysm, but quite unusual to see it in this location. It's some connection between aorta to LV, right? You can see there's a gap there and something connecting between aorta and LV. So what are the things you know of that connect between aorta and LV? We know AR, there's a jet from aorta to LV. What else? What are the connections between aorta into left ventricle? Diverticulums will typically be from LV out. You know, they'll be from the apex of the LV and they will go out into the body. But from aorta to LV, either you have a cusp, aortic cusp with a rupture, you can have AR, and there is, yes, so you can have a ruptured sinus of Valsalva. And this thing is actually something which is called an aortico left ventricular tunnel. So the T is tunnel, and this is the commonest aortico-cameral tunnel, where it goes from the aorta to a cameral means it can go to LV, it can go to RV, it can go to RA, it can go to any chamber. Okay, so now I shall move to another topic. What is the diagnosis here? This is a 5-chamber view tipping up, still image. Anyone? So you see this is your LV here, this is your aorta, right? And now you're seeing a connection here, right? Now this could be an LPA from aorta, this could be an AP window, right? This is how AP window will look in your 5-chamber view. That's why I put it up for you. Whenever you're doing newborns, you need to look. I'm going to show you when you're doing a newborn, you need to always look at this view where you've got 5-chamber view, that's your aorta, right? And you have to look in this area to see if you see any gap, because the pulmonary artery lies right here, right? So if you see a gap like this, that is suggestive of an AP window. What are the other echo windows which are used to diagnose an AP window? Other echo views for AP window. So this is a 5-chamber view tipping up. Where else can you see an AP window? So suprasternal view, you can look, yes. So in suprasternal view, so short axis, parasternal axis, subcostal, which is this 5-chamber tipping up, high parasternal short axis, and also remember, yes, your suprasternal. When you see your arch like this, right, typically your RPA lies here. So if you see a gap here in your suprasternal view, that is also suggestive of an AP window. So if you look at this, this is your high short axis view on the right, and this is your, on the left is your regular short axis. So when we say high short axis, it means you go one space higher And that's when you can get an image like this, where you won't miss an AP window. And this is important. We actually reported about almost 10 years ago a series of patients with missed AP windows. This was, we found we had cases who had like mild heart failure symptoms. We diagnosed an ALD and sent them home. On follow-up, when they came back, we found there was an AP window. We had a case of tetralogy of fellow. We missed an AP window because we only saw the overriding aorta and missed the AP window part. So I think it's important to use a mix of these views. 5-chamber tipping up, that's from your subcostal, regular short axis, high parasternal short axis, and your suprasternal view. Okay. Now, the cause of an AP window, embryology, is basically failure of the conotruncal ridges to fuse. Are there any genetic associations with AP window that you know of? Any genetic associations? So, familial AP window is quite unusual. So, generally in AP window, there are no genetic associations, no known. Chromosome 7p, I'm not sure if that has. But typically, if you think about it, AP window, it's considered non-neural crest, right? It's not associated with DiGeorge. It's not associated with 22q11. So it's generally AP window is considered to not have genetic association. Now, how do you differentiate it from truncus and AP window? Now, truncus, as we know, and we did in the last class, truncus is associated with DiGeorge, with 22q11. Clinically or by echo, how do you differentiate these two? Via the semilunar valve. So in AP window, you have pulmonary valve. In truncus, you don't have an pulmonary valve. Okay, we'll move on to anatomy. Whose classification is this? Type 1, proximal defect in the wall. So this is yes. So this is Mori or some is Van, there's some modification which is your Van Meerhoop. So if you look at it, type 1 is where you have a connection between the main pulmonary artery and the aorta. Type 2 is where there is that extends into the pulmonary artery. So it's between the right pulmonary artery and the aorta. And type 3 is the whole way, aorta and pulmonary artery. Now, which of these is the most common? Type 1, type 2, or type 3? Most common. Type 1. So type 1 is the most common AP window. Now, if you see in type 3, where you have the AP window across from the aorta into RPA, that is the one that can sometimes have anomalous origin of the right pulmonary artery. So apart from being an AP window, the RPA is actually coming off the aorta. And apart from closing the AP window, one needs to reconnect the right pulmonary artery. So what are the associated lesions with AP window? What is the most common associated lesion with AP window? More than half, and remember this, that more than half of patients with AP window will have some additional lesions. Okay, so what are the lesions? So most common is not PDA, but okay, you may have, but PDA is most common, remember, with hemi-truncus. So interrupted aortic arch. So please remember this association of AP window with interrupted aortic arch, because you may get so fixated on the AP window that you miss the interruption. So interrupted aortic arch. What else? Other associations? And which type of interrupted aortic arch? Type A or type B? So which is the type of interrupted aortic arch you get with, okay, so type A. Which is the type of interrupted aortic arch you get with truncus? Type B. And so type A, type B is the one that is associated with DiGeorge and with conotruncal. Here you get type A. And remember that this interrupted aortic arch is the most common association of AP window. This is very important to remember because when you diagnose your aortic pulmonary window, you need to also look at your aortic arch. So the associations are most common interruption of the aortic arch, then aortic origin of the RPA, where the RPA comes off from the aorta, which you see in type 2. You can have sometimes tetralogy of Fallot, you can have anomalous origin of coronary arteries, and rarely you can have PDA, VSD, TG, and so on. But association, if you're asked, you need to know aortic origin of RPA and definitely interruption of the aortic arch, which is type A. Okay? Which type of interruption? Type B, and type B is the one that has the association with DiGeorge syndrome. Okay, next question. Now, the amount of blood that is shunted from the aorta to the pulmonary artery in an AP window is directly related to what? What is it related to? It's related to two things. One is the size, right? How big the defect is, yes. So if it's a restrictive AP window, obviously less. And what's the second thing? The pulmonary resistance. So the size of the defect and the pulmonary vascular resistance. So if you have a large defect and pulmonary resistance is low, you'll be in heart failure. As the lungs get damaged and the pulmonary resistance goes up, your heart failure symptoms will disappear. So it's not really related to pulmonary pressure. It is related to pulmonary vascular resistance. All clear on that? If any doubt, please stop me. Now, what is the PA pressure in a large AP window? What is the pulmonary artery pressure in a large AP window? Large AP window, what is PA pressure? Systemic, right? It is systemic. In a restrictive AP window, what is the doppler signal that you get? What is the doppler signal in a restrictive AP window? Because in a restrictive AP window, PA pressure is not going to be systemic because it's now there's restriction. So holodiastolic, anything else? So think about it in an AP window, right? If this is your aorta and the aortic pressure is 100 by 60, let's say, right? And now you have a restrictive AP window here, let's say, okay? And I tell you that the gradient across this is 60. So, if there is a restriction, both as in systole as well as in diastole, there's going to be restriction. So, your PA pressure will be, let's say, if I tell you gradient is 60, PA pressure is, let's say, 40 by 20, right? So, now in systole you have a gradient, in diastole you have a gradient. So, the typical Doppler signal will be what? Typical Doppler signal will be continuous, right? So this is one other, apart from PDA, in restrictive AP windows also you can get continuous Doppler signals in the arch region. And yes, flow reversal is something you do see, but in restrictive AP window, what is the Doppler signal in the AP window? The answer is continuous, because in systole as well as in diastole, there is a gradient between aorta and pulmonary artery. Okay, all clear on that? Now, early diagnosis. What are the symptoms? How do you diagnose it clinically? An AP window? Anyone? Clinical symptoms of a large AP window? So, heart failure with bounding pulse. That's right. Heart failure, white pulse pressure. So, basically, you will have tachypnea, sweating, failure to thrive, respiratory distress, all the features of heart failure along with bounding pulse. What is the differential diagnosis of heart failure with bounding pulse? So PDA, heart failure with bounding pulse. What else? So PDA, severe AR, okay, severe AR. What else? Bounding pulse, heart failure. Truncus, hemi-truncus, right? And all of these will give you bounding pulses and heart failure. So on examination in an AP window, you will have heart failure, bounding pulses, S2 will be loud with a loud P2 component. You may have a systolic ejection murmur, all that flow going across the aortic valve, and an MDM. Where is the MDM? Why do you get an MDM in an AP window? Apex at the mitral valve, similar to why you get an MDM in a VSD or a PDA. All that blood coming back to LA has to go across the mitral valve and give you a flow murmur. Now, in an AP window, if you hear a machinery murmur in the upper left sternal border, in which situation is it heard? A machinery murmur in the upper left sternal border. Diagnosis AP window. Yes, so if it is a restrictive AP window, you get a machinery murmur. So the differential diagnosis of a PDA, similarly, if you don't see a PDA, you should be thinking of a restrictive AP window and look in your suprasternal view. Okay, good. Chest X-ray, you get cardiomegaly, plethora, you get a prominent MPA. Now, how do you clinically differentiate a large AP window from a large VSD? How do you clinically So, yes, no wide pulse pressure. So, in a AP window, you have the bounding pulse, VSD pulse is normal. How do you clinically differentiate AP window from a truncus? From a truncus? Click OK, click OK. Anything else? Cyanosis, saturation. So truncus, remember, will never be a 100%. So truncus will have some desaturation, whereas AP window, at least in the early stages when they're operable, they will be fully saturated. Truncus, you can have clicks, you can have diastolic murmurs from truncal regurg, but put your O2 sat. If you've got desaturation, it goes with truncus. No desaturation goes with AP window. Okay? So, someone refers you a patient with heart failure. You do the echo. How do you suspect it? What are the echo clues to an AP window before you see the AP window? Okay, dilated LALV. Anything else? Reversal of flow. So you'll have LALV dilation in the absence of a VSD or PDA. You'll also get increased pulmonary venous return, right? Because the same thing that causes your MDM, all that flow going to lung, coming back, increased pulmonary venous flow, and yes, reversal of flow in the descending aorta is a clue to AP window. Now, how do you differentiate from a PDA on echo? Obviously, you know, when you have reversal of flow, in the PDA, it stops at the PDA level, whereas in AP window, it goes all the way to the arch. Is there any other echo finding that can help you differentiate these two, PDA and AP window? Any direction of flow in the pulmonary artery? So PDA reversal will be only till transverse arch. AP window, it will go all the way into ascending aorta. That's one. And the other thing you can look for is abnormal continuous forward flow. If you think about it, when you look at your short axis view, right, in a PDA, you'll have a red flow coming in. So you've got, that is your diastolic flow into the PA. In a AP window, it is from aorta into PA. You will get a continuous forward flow. It's like when you're looking at that PA, normally you get only systolic blue. But here you will get systolic as well as diastolic. You'll be seeing this kind of blue. You get a feeling that even in diastole there's forward flow. And that is another clue to an AP window. So I want you, whenever you're doing your short axis view, to keep looking at that MPS flow, because you'll see how it looks with just normal flow, just in systole blue. But in an AP window, systole, diastole, there's a continuous forward push into that PA. Okay? All clear on that? Okay, next question. If you don't see reversal of flow, now you all know what is reversal, right? I know some of you are new fellows, but if you've got your aorta, normally you will have, if you look from suprasternal, you'll have a blue flow because it's going downwards in the aorta. Reversal means what you see here in the image, there's a red flow coming back. And you can see on the doppler also, you'll have a forward flow in systole, and in diastole, you'll have flow coming back. So if you don't see reversal, what can you do to find it? You can turn the scale down. You turn your Nyquist limit down, and then you can pick it up. So if your scale is at 90, 100, sometimes you don't get it. So you turn it down to 40, 50 and take a look. Okay? Now, prognosis of AP windows. Why does an AP window cause early pulmonary vascular damage compared to a VSD? Anyone? So high pressure, yes, high pressure even VSD has, right? Large VSD also has high pressure. So direct pressure transmission in whole cardiac cycle. So yes, in a VSD, you are transmitting high pressure only in systole. In an AP window, you are transmitting pressure in systole as well as in diastole. So that is why with AP window, with PDA, large PDAs, with truncus, with all of these, you get early pulmonary vascular damage compared to a VSD. So what are the two features which would suggest inoperability? When do you say, okay, this is there now, this AP window, I cannot send to the operating room? Which two features would suggest inoperability? Anyone? Okay, so no flow reversal. So if you have an AP window and you like turn out in your scale and there's still no flow reversal, the kid has no bounding pulses, I'd be very worried. So if there's no flow reversal and if there's cyanosis. Remember, an AP window is actually a pink condition because it's a left to right shunt. So you have all that extra blood going to the lung, coming back to left atrium, going back out to the aorta. So it's pink. So absence of reversal of flow is a feature that is very worrisome. But more worrisome is cyanosis, because once you develop cyanosis, it is like your VSD. If you have a cyanotic VSD, they are not operable, right? They are got Eisenmengers. You see a VSD with 75% SAT, you're not going to send them to the operating room. And the same goes for AP window. Okay, all clear on that? Now, management of AP window, what do you do? And what route do you surgeons typically follow? Management. Management, what do you do? So trans-aortic closure. You go through the aorta typically. So some people do through a PA patch and close it off. So typically, this is done at what age? When would you fix a large AP window? What age? So ASAP. Again, like Hemi-truncus, AP window isn't going anywhere. It's not like a VSD that may get smaller. So you need to fix it ASAP. In the neonatal period is fine as well. So in AP window management, you can give digoxin, Lasix if you need to, family needs to arrange money, couple of weeks, no problem. And you plan for surgical repair. Sometimes you have to put them on prostaglandin. When is that? When do you need to put them on prostaglandin? Prostaglandin? Anyone? What are the associated What did I tell you is commonly associated? Yes, so aortic arch interruption. Which type with AP window? Type A. Remember AP window, type A. So if commonly associated with interrupted aortic arch, so therefore when you see it, you need to start them on prostaglandin and then fix the AP window as well as the interrupted arch at the same time. Now, if you have a moderate AP window, that means a restrictive AP window, then what is the management? Okay, one question. How many of the AP windows are restrictive? Typically, what percentage of AP windows are restrictive? Like 10%, 30%, 50%, 80%? Anyone? Not so high, typically 10%. So 90% are generally large. So generally when you talk about AP, that's why AP window management, we talk about early vascular damage, we talk about needing to go transaortic and put a surgical patch and everything. 10% of them can be restrictive. Now if they are restrictive, then what is the procedure you can do? So you could do device closure. Some people have even tried ligation. The results, if it's very small, they just go surgically and ligate it. But yes, definitely you could consider device closure if it's a restrictive AP window. So the incidence of restriction is only 10%. So the vast majority, 90%, will be large, have early pulmonary vascular damage, cause heart failure along with bounding pulses, and require surgical patch closure, typically by a transaortic route, need to look for the arch, since interrupted aortic arch type A is a common associated lesion. Okay, and I think with that, I have one more question. Post-op follow-up. So once you fix the AP window, what do you look for? What do you do when they come back to you? 6 weeks, 6 months, 1 year. What is your post-op follow-up? What are you looking for? Post-op follow-up, what are you looking for? Anyone? So you've gone through the aorta, remember? And then you put a patch. So you need to look for any residual leaks. You put a patch on the PA, you need to look for any pulmonary artery stenosis, right? And typically these leaks and all don't occur unless, sometimes you've done ligation, if you've ligated it, or if surgeon has chosen to put a patch through pulmonary artery rather than transaortic. It's not that common. So, but anyway, you look for stenosis and you look for residual leaks on follow-up. And so with that, I shall end and wish you a very happy Jan 26th. And we'll continue next week. If any of you have any classes you would like, please email me. I know some, I got one suggestion on what basics of what are the different types of surgeries. So we can do that. So, any of these topics that you feel like, because we may sometimes run ahead into LV cameral fistulas and so on. If you think you'd like any topics, then just let me know and I'll put it into the Feb schedule. Okay. Thank you and see you next week. Ciao, ciao.